what is going on? How can this be happening? Literally wasting $1.5 trillion a year while almost 500,000 excess Americans' deaths are taking place every year. How can it be going on? How can this look like normal healthcare performance to us within the United States? And the answer is that the knowledge climate that the doctors are in, and the public too, but it's important to have the doctors out front here. The knowledge climate that the doctors are in makes sense, normalizes this very poor performance. So how can so many hardworking, dedicated, smart healthcare professionals not be seeing what's going on? And that's what I want to address next. So I want to talk about the epistemologic. That means the knowledge. Epistemology is the philosophy of knowledge. And I want to talk about how the epistemological climate has changed in the United States to make this extremely poor performance, I mean, historically unique poor performance of our healthcare look normal. And the answer in broad brushstrokes is that the knowledge that doctors rely on and the public, medical knowledge has been transformed from a public good into a commodity. It was a public good. The purpose of it was to optimize the health of Americans most effectively and efficiently. And now it's become a commodity. It's a tool by which the financial benefits are delivered to investors. And I'm going to explain how this change has happened in our country. So I was a Robert Wood Johnson Fellow in 1980 to 82. That's getting further away as the years go on. But as a fellow in family medicine, being trained to be an academic family doctor, we looked at the difference between what we thought as family physicians good healthcare was and what the medical world thought good healthcare was, the conventional medical paradigm. And I think there were four keys to the medical paradigm at the time. Reductionism, meaning the idea that when we really know all that we can know about medicine and healthcare, it'll be reduced to chemistry and physics. This is an anti-holistic point of view, and I'm sure all the listeners in the audience understand this well, that they want to talk about the meaning and purpose and quality of their lives, and the doctors want to talk about their level of sodium. So reductionism is point one. Point two is that disease emanates in a unit, it originates in a unidirectional, as unidirectional causality, meaning we go from dysfunction at the lowest, smallest level of function, the molecule, the genetics and so forth, smallest level of function, and it percolates upwards to affect the whole organism. The third principle is positivism, which means the assumption that those things that are not amenable to scientific investigation are not important. And an example of that would be how you feel about how your life is going is not an important fact to a positivist. And that's the assumption that medical education and medical practice is based on. Now, there's some lip service to acknowledging how touchy-feely holistic medicine is a good thing. But really, the truth is that the docs believe that if you can't study it scientifically, it's not important. And finally, individualism, that the individual is the focus of care, that it's not communities, that it's not the way our political priorities. It's not our social organization. It's just the individual. So when the individual comes in with hypertension and anxiety, it's about treating them with medicine rather than figuring out how that individual is fitting into the social context of his or her family and his or her community and his or her professional role. It's not about that. It's about the individual. And so we treat that with drugs, and we treat that as this reductionist pathology. Now, let's do a little history here. This problem really started, the problem of the commercialization of the knowledge that informs physicians. It really started in the 70s when grants from the NIH, the percentage of grants from the NIH that were successfully funded started to go down. And that meant that university researchers, rather than being able to count on the NIH, university researchers had to start to turn to industry for research money to do what they wanted to do, what they wanted to do was a public service. This is when things started to change. So an article that came out in the journal Science in 1982 said scientists, this is a quote, scientists who 10 years ago would have snubbed their academic noses at industrial money now eagerly seek it out. So it became normal, even prestigious, for academic physicians to seek out drug industry and other commercial entities' money to do their studies. And I can't say this enough, and I may try, but the commercial entities are trying to make money. They're not trying to make health. And as the 70s bore on and people had to turn, academic researchers had to turn to industry to fund their research, it normalized doing commercial research as the goal of the academic physician. And this was a radical change. And then we got another huge change in the 1970s. You may remember that Japan was kind of picking America's pocket with Japanese cars. Japanese cars weren't always normal on the road. It became a new phenomenon in the 70s. And Japanese technology, their kind of pre-computer technology was starting to take over from Americans. And the problem, as seen by our government, was that research grants were being given to universities, but the research products that were developed, that were patented, weren't being commercialized. So the products weren't getting out into society, and therefore Americans were being deprived of the benefits of those research-generated products, and American industry was not gaining in competitiveness because they had access to these new findings that were patented. So the solution was the BiDol Act, which was passed in 1980. And what the BiDol Act did is it allowed researchers in nonprofit institutions to use their federal money to develop products, patent the products, and the BiDol Act let the researchers keep the money from the patents, the money that was made by the patents. The money did not go back to the government. So suddenly there was an enormous push for academics who were doing public interest research to do commercializable research. And the purpose of that research, again, was not first and foremost to improve Americans' health and healthcare. It was first and foremost to make money. And this is where the purpose of American medical research really underwent a radical change. Excuse me, let me get a drink of water. And we can see how quickly things changed in terms of the conduct of pharmaceutical research. In this graph from the New England Journal of Medicine, it starts in 1994, but if we go back to 1991, the data shows that in 1991, 80% of clinical trials that were done in the United States were done in academic medical centers. 1991, 81%, and then it went down to 63% in 1994. But 80% in 1991, and by 2004, only 26% of clinical trials done by funded by pharmaceutical industry, only 26% of those trials were done in academic medical centers, and the rest were done by what's called contract research organizations. These are professional for-profit companies that do the research that the drug company designs, and they conduct the research and they gather the data, and then they, in conjunction with the drug company, analyze the research and write the reports that will tell doctors and the public what their research showed. But in 1991, when 80% of the public, when 80% of the research funded by drug companies was done in academic medical centers, the academics could use their independence from industry to design those studies in a fair way, to make fair comparisons about doses, and to make sure that the people that were enrolled in the study would reflect the people to whom the study results would be applied. And there was this academic independence that really contributed to the public nature of the information that was generated as a public good. But by the time we got to 2004, only 26% of these studies were being done in academic medical centers. And that meant that academic medical centers had to compete to maintain their 26% of research contracts, which is a significant source of income, which they lost. That motivated a deputy editor at the Journal of the American Medical Association to say, because of the competition to maintain even their 26% of contracts, they were engaged in a race to the ethical bottom in terms of ensuring that the information that was generated would serve the public interest and not the private interest. So now we've got the federal research grants are going down. The universities now are in the marketplace. The president of Harvard University, Derek Bach, wrote a book called Universities in the Marketplace about the shifts that were taking place as a result of the BiDol Act, that the universities were no longer independent overseers of public knowledge, that they became commercial actors. And now we see that the research is largely, or about a third of it, is ripped out of the academic medical centers. 2/3 of it is ripped out of the academic medical centers and delivered to private for-profit research companies.